I am the third year resident in palliative medicine, Department of Palliative Medicine of MNG Institute of Oncology and Regional Cancer Center, Hyderabad. So today I have been given the task of discussing the topic delirium with you. I'll just share the slides with you. One moment, please. Is the slide visible?
Yes, sir. Yes.
Yes,
Okay.
go ahead.
Shall I
It's
start, ma'am?
clear. Yes, please.
Okay. So, like ma'am mentioned, delirium is one of the symptoms which all of you might have encountered in your practice at one point or another. But most of the time, we might not be able to understand what exactly delirium is or what are the based on the finer subtleties of delirium as well. Like there are multiple subtypes of delirium as such. So the major objective of today's session is to help you understand what exactly is the definition of delirium, what are the causes of delirium, its clinical features, and how do we manage it. So the first question is, how common is delirium, especially from a palliative care perspective? How often do you encounter a patient who is having delirium, who is suffering from delirium, and how important is it to manage it as such? So this was one of the studies which was published in 2018 February in the Indian Journal of Psychiatry, which found out that the incidence rate of delirium ranges from 3 to 42% in hospitalized patients. And also the prevalence varies from 5 to 44% among these hospitalized patients. So if you look at the raw numbers itself, like 40% or 45% is a very high number as such. So we encounter delirium or patients with delirium are much more common than what we anticipate as such. And with regards to ICU prevalence, it goes up from 26.2% to 68.2%, and the incidence rate vary from 9.2% to 60% almost. So if in ICU you are seeing 10 patients, nearly 6 of them might be suffering from delirium or had delirium is what one of the articles which is published. So the presence of delirium is very much high. Like I mentioned, how is it important? Why is the prevalence of delirium is important to us, is relevant to us? As such, one thing is delirium is usually associated with high mortality rate and high morbidity rate as well. So not only it affects the quality of life of the patient, it also affects the quality of life of the caregivers, and also it affects provides us much more better idea about the prognosis of the patient, which in turn helps us in making a better care plan or communicating with both the patient as well as the caregivers regarding what exactly is happening with the patient and with regards to a disease trajectory as such. Another thing is that more due to delirium, there is increased incidence of hospitalization, which in turn will also increase the expenditure or the cost acquired by the patient or their family members due to the frequent admission of the patient as such. So in all, getting an idea of what exactly delirium is and how do we manage it is of paramount importance to us, especially as palliative care physicians. Now, how do we exactly define delirium? So, when we go with the definition of delirium, multiple criteria are there. The DSM-5 criteria is the latest one which we follow. Also, there's the ICD-11 criteria. But the definition of delirium as such, what it says is that delirium is defined as a global cerebral dysfunction characterized by concurrent disturbances in the level of alertness, awareness, attention, thinking, perception, memory, psychomotor behavior, mood, and sleep-wake cycle. And it's usually of acute onset, and most of the time, delirium is a reversible process. Now, if you go back to the definition as such, there are certain terms in this, like one is global cerebral dysfunction. Now, with regards to the pathophysiology of delirium, not one exact pathway has been found to be the causative agent of delirium. What has been found is that there are multiple pathways or multiple etiological factors which play a role in delirium. Most of the time, what they have found is that the neurotransmitter pathway, be the dopaminergic pathway or the serotonergic pathway or the glutamatergic pathway, all the pathways are affected, which in turn causes a concurrent disturbances in the level of alertness, awareness. So I think most of you might have seen a patient with delirium. How many of you have seen a case with delirium? Can you just put it in the chat box? Has no one seen a case of delirium or Okay, terminal
There are
delirium.
a couple of responses in the chat box.
So whenever we see a patient with delirium, there are certain things which you notice. One is the patient is not that alert. Like most of the time, patient might not be able to maintain eye contact or might be looking or gazing at somewhere else. And next is regarding awareness. If you've seen a patient with delirium, most of the time when we ask them with regards to their name or where they are, who the caregiver is, the patient won't be able to is not able to recall where exactly he or she is, who is taking care of them as such. And sometimes there's a defect in perception also. This is not hallucinations or delusions as such. And there's an alteration in sleep-wake cycle. So all the terms which we can put into a definition are all the symptoms which you find in delirium. I'll be talking about the symptoms and the manifestation later on, but just to make you understand is that's why I went back to this point. And another thing is delirium is always of an acute onset or an abrupt onset. A patient who has delirium will develop it acutely is one thing. So that means a patient who you saw today, there are high chances that he or she might develop delirium tomorrow also. It's not like the delirium will be there for the longer time as such. It will is of acute onset. And one thing you have to keep in mind is that most of the time delirium is a reversible process. Reversible process in the sense, if we find out what exactly is the causative agent or the triggering factor of delirium, once we deal with the trigger factor or causative agent, the delirium is also reversed. However, there's just one situation in which delirium cannot be reversed. That is, like one of them put in the chat box, terminal delirium or delirium which we face in end of life situation as such. Now, the reason why terminal delirium is irreversible is because of the etiology itself. Most of the times in reversible process, delirium is a reversible process because the etiology can be something as simple as an infection to dehydration to a constipation or unsatisfied pain management as such. However, in terminal delirium, most of the time the etiological factor is due to the multi-organ dysfunction or multi-organ failure that happens during end-of-life situation. As such a process is irreversible, the delirium or terminal delirium which manifests during that time, that is also irreversible, is what we usually see. Now, like I mentioned earlier, right now, what we are following worldwide are the two criteria. One is the DSM-5 criteria and other is ICD-11 criteria. So what the DSM-5 criteria mentions for diagnosing delirium is that there are 5 points. One is the patient should have disrupted attention. That means there should be a difficulty in directing, focusing, sustaining or shifting attention. And awareness, that is reduced orientation to environment. So this is one thing which we usually do in our morning round. So whenever we see the patient, we introduce ourselves, and when we speak to the patient, we find that sometimes the patient won't be able to maintain an eye to eye contact or might be looking or gazing at someplace else. Even if we manage to take the patient's attention, they might not be able to focus the attention or sustain the attention for a much more longer time. Like within a couple of seconds or 4 5 seconds, they might get distracted or might be looking at somewhere else. The next point is awareness. So, like you mentioned, if you have noticed during our rounds, so whenever we are interacting with the patients, whenever we suspect the patients having delirium or such, there are certain questions which we ask. These are whether they're aware of where the patient is exactly, who is the primary caregiver with the patient, what date it is, what time it is. So these are certain questions that we routinely ask during our interaction with the patient so that we are well aware of the patient's orientation to the environment and their awareness status as such. The reason I mentioned this is that sometimes the patient will be communicating perfectly and is all right, but he or she might not be able to recall where exactly they are or what exact time of the day it is. So all these are warning signs or points towards delirium and such. The next criteria is it's a change from baseline that develops over hours to days and fluctuates in course. What it means is that, like I mentioned earlier, it's an acute onset phenomenon, delirium as such. And once delirium manifests, it doesn't be in the same situation throughout the day. That means there's a fluctuation in delirium onset as such. Sometimes the patient might be all right during the morning hours. However, during the evening time or during the afternoon time, he or she might develop delirium, which is something which we call as sundowning phenomena. And this course fluctuates. Hence, it's of paramount importance that whenever we are seeing a patient with delirium, we need to ensure that the staff who are in duty, like each shift, monitors the patient's conscious level and attention span, and they maintain a delirium chart or delirium scoring as such. Because sometimes you might see the patient all right during the morning hours, but when we speak to the caregivers or the attendants who are with the patient, What they say is that the entire night the patient was restless, he or she did not sleep, and it was causing huge headache for all of them. He was roaming around in the ward or trying to pull out the IV lines and catheters as such. So the fluctuating course is one thing which you have to keep in our mind whenever we are speaking on delirium as such. And the next criteria is there is an additional cognitive problem. This can be any impairment to the memory, language, or perception. In perception, we are talking about delusions or hallucination as such. Like there might be the patient, when we speak to them, they might say there's someone is standing there or something else is coming and going. All these are the additional cognitive problems, which is an example of perceptive problems as such. And the fourth criteria is it's not better explained by another neurocognitive disorder and not associated with a state of reduced arousal like coma. And history, physical examination, laboratory findings, all this suggest the mental state is a direct physiological result of another medical condition, substance intoxication or withdrawal or exposure to a toxin or multiple etiological factors as such. So all these criteria are also giving us certain symptoms which will manifest when you are seeing with patient with delirium. So what I discussed till now is the DSM-5 criteria. Other than that, there's one more categorization, which is the ICD-11. Apart from the DSM-5 criteria's 5 points, ICD-11 also puts a point about the disturbance of the sleep-wake cycle, including reduced arousal of the acute onset or total sleep loss with reversal of the sleep-wake cycle may also be present. So this is one thing which you may also notice when you are seeing us rounding the patients. So sometimes when we always ask the patient regarding their sleep cycle, how their sleep was. It is of two importance are there. One, it helps us to understand how much symptom burden the patient is having and how it is helping with their sleep cycle as such. If the symptom burden has been decreased a bit, the patient's sleep be routine, might be regularized, which will also help the patient and the lifestyle of the caregivers also. However, whenever there's a sleep cycle alteration, that is, they say that the patient is sleeping through the entire day and is awake during the entire night, we must be aware that the chances or the risk of the patient developing delirium will be very much high. So the alteration of sleep wake cycle is one of the things which we now call as the prodromal symptoms, like it manifests before the onset of delirium as such. So whenever we are asking of the sleep pattern of the patient, always inquire whether they're sleeping more during the daytime and not sleeping during nighttime as. All these are certain hints or clues which help us to clinch the diagnosis of delirium as such. I hope this much part is clear for all of you. So now I will go to the causes of delirium. If any doubts are there, you can just put it in the chat box. I'll try to address it after the session is over. So regarding the causes of delirium. So like any disease as such, we can classify delirium as, like I mentioned earlier, we manifests as a global cerebral dysfunction. So the causes also we categorize it in the basis of direct CNS causes, indirect CNS causes. So two of the direct CNS causes are primary brain tumors and brain metastasis as such, while the indirect causes are metabolic encephalopathy, electrolyte imbalance, infections, hematological abnormalities, and nutritional deficiencies. And there are certain other factors like medications, like benzodiazepines, opioids, anticholinergics, TCAs or tricyclic antidepressants. Certain anticonvulsants as such can also cause delirium. Then there is corticosteroids. Sometimes poor management of pain can also cause delirium, and poor bowel and bladder habits or improper management bowel and bladder habits can also manifest as delirium. So of this, if you are able to recall, most of patients who we see or who are under our care might be using multiple medications like benzodiazepine, opioids, anticholinergics, TCs, anticonvulsants, or corticosteroids. So all these medications themselves can manifest delirium in these patients. So special care must be taken whenever we are prescribing these medications, considering the patient's age and all, and with other risk factors also. And one thing we have to keep in our mind is that most of the time what happens is that we might see a patient, we might get a call or referral for a patient who is in pain. We might start the patient on opioids or morphine as such. After 1 day or 2 days, we get another call saying the patient has developed altered behavior as such. Even though morphine or opioids can cause delirium, don't put them as a first drug or first agent that will always cause delirium. Like I mentioned, they might be on benzodiazepine, they might be on steroids, they might be on TCS, they might be also be on anticholinergics. All these medications can also cause delirium also. So always keep your mind open to look for other medication, other causes of delirium, and after that only go into like rule out morphine as one of the causes of delirium as such. Reason I'm mentioning that again is that most of the time we usually put delirium and put it as one of the causes of morphine as one of the causes of delirium as such. So when we discussed about the cause, now there are certain risk factors for patients who are developing delirium. These are age more than 65 years. They might have a pre-existing cognitive impairment like dementia, immobility, like prolonged bedbound patient. It can be due to anything like a stroke or due to post-surgical patient, dehydration, multiple medications. So like the medication which I mentioned, so one of the guidelines for delirium says that if the patient is on more than three of those medications, then there's high risk that this patient might develop delirium. And the patient also had a history of delirium prior admission. So all these are the pre-existing risk factors that the patient might develop delirium. To this, you can also add pain or uncontrolled symptom management, also indwelling catheter, urinary retention, constipation also. All these are things that can manifest delirium. And if you go through the risk factors, majority of the patients who are availing palliative care services come under this. So most of the patients which we see are maybe of more than say, 65 years of age. They might have a pre-existing cognitive impairment. They might be immobile due to any stroke or post-surgical intervention. They might be on multiple medications, and they might also have a history of delirium. So all these are the risk factors which can put the patients at risk of developing delirium as such. So now to the clinical features. So if you're able to recall the definition of what I said was is a global cerebral dysfunction. So concurrent problems in attention, awareness, perception, and mood of the patient. So these are the symptoms which we say for delirium. There are certain prodromal symptoms. These are restlessness, anxiety, sleep disturbances, and irritability. Prodromal in the sense, these are certain symptoms which we get to know even before the patient develops delirium. So most of the time when we get a call for any patient, we inquire about sleep, they may say that the sleep cycle is altered. So when we talk to the patient, what they say is that nighttime they're getting more anxious. They don't know what to do. They might be lying down for some time. They might be sitting for some time. They might be roaming around for some time. Like they are not in one fixed position for the entire night. As they might be just going. This restlessness is one of the prodromal symptoms of delirium. If you are able to find out the patient in this stage itself, it's much more easier to manage the patient. Then the other clinical features of delirium are it's of an abrupt onset and there's a fluctuating course, like I mentioned earlier. There's a disorientation to the person, place, and time. There's a disturbance in the level of awareness. There are certain cognitive symptoms also, like memory impairment, apraxia, agnosia, language disturbances. There is also incoherent speech and perceptual disturbances are also there, like hallucinations, illusions, or even delusions as such. Other than that, there are certain motor behaviors also. These are increased or decreased activity, wandering, restlessness, like I mentioned earlier, increased or decreased speed of actions, combativeness, or apathy. So these are the certain clinical features of delirium. Is the presentation clear till now? Is there any doubts as of now? You can just put in the chat box if any doubts are there. Otherwise, I'll just proceed. Okay. So I'll just proceed with the presentation then. So delirium, there are further in delirium, there are further three classification like categorization delirium. We classify delirium into three categories. These are hyperactive delirium, hypoactive delirium, and mixed delirium. Of this, I'm pretty much sure all of you might have seen a patient with hyperactive delirium as such. Because hyperactive delirium is one thing which we all of us might have encountered during our practice, and one thing which we'll never miss as such. And the symptoms of hyperactive delirium, just like the name is suggested, there is increased activity, restlessness, agitation, even combativeness. Hyperactive delirium class thing is we might see a patient who's pulling out his IV lines, catheters, or NG tube, all such things. So all these things are symptoms which we see in hyperactive delirium. And sometimes it is DDs or differential diagnosis are psychosis as well as mania. So hyperactive delirium is one thing which we never miss and is much more easier for us to catch hold of and to diagnose as. However, when it comes to hyperactive delirium, I'm pretty much sure all of you might have seen a patient with hyperactive delirium, but you might have missed it. Can you anyone put in the chat box whether they have seen a patient with hyperactive delirium as such? I'm not asking for hyperactive delirium. I'm asking about hyperactive delirium. Have any of you seen any patient with hyperactive delirium in your practice? Simple yes or no would suffice in the chat box. So So can you just put in the chat box what all, or you can unmute yourself also. You can say what all symptoms did you see in these patients? Those who have mentioned yes. So some symptoms which we see in hyperactive delirium are as decreased awareness or lethargy and delayed response to any of our queries and delayed activity also. Like they might be active as such, but the time taken for the patient to initiate after doing any activity, it's much more prolonged as such. And the reason why we miss hyperactive delirium is that we usually misdiagnose it as something as fatigue or even depression also in certain cases. And sometimes it's also mistaken as dementia. Like I mentioned earlier, most of if the patients have other neurocognitive impairment also, delirium can manifest. So due to these things, we might miss delirium as such. The reason being is that due to the, we might say that the caregivers also might tell to us that the patient has not taken anything, that's why he's a bit dull or not doing any activity. All these are signs and symptoms of hyperactive delirium. The reason why I mention it is that it's one of the most common form of delirium and we miss it much more commonly. Or it's like one of them put in the chat box, underdiagnosed and not treated also. And there is mixed delirium also, which has symptoms of both hyper as well as hyperactive delirium. Now, when it comes to the symptom burdens or the impairment of delirium to the quality of life, it is not like one form of delirium has got much more impairment compared to the other forms of delirium. All three forms of delirium has got poor prognosis and its add-on burden to the symptoms is much more high and it causes equal distress to the patient. Some studies have even found that the hyperactive delirium is one thing which has caused much more distress to the patient and caregiver compared to hyperactive delirium. And the reason being is that the patient will be sleeping the entire time. The lack of activity or lack of communication of the patient with the caregiver is one thing which will severely burden the caregiver's stress as such. And how to differentiate between depression and the hyperactive delirium is, like I mentioned earlier, delirium is of an acute onset as such, and it has usually got a reversal curve. Most of the time, depression, it's not like an acute onset. Like the patient is all right in the morning, it's depression, it's not on such a manifestation. Delirium as such, it's of acute onset, and the reversal causes one thing which we manifest as, which we put as criteria for delirium as such. So now we go into the management part. So how exactly do we manage a patient with delirium? Or should we, like one of the persons who put in chat box, should we manage a patient who is not having that much symptoms of delirium is one thing which we always arise. So so this is one of the latest articles or publication that came out. It came in 2022, I think so. The Dilemma of Treating Delirium by Mira Raga. So this is one of the worldwide renowned physician who has got much extensive work in delirium. So if you can see the highlighted portion, the gold standard approach based on expert consensus is to institute management for delirium precipitants, supported by non-pharmacological essential care with the support of an interdisciplinary team. Medication management should be used sparingly and for a limited period of time whenever possible for severe perceptual disturbances or agitation which has not improved with non-pharmacological approaches. So what the worldwide consensus of management delirium is that instead of managing the major principle of managing delirium is that to find out what exactly is the causative agent or trigger factor for delirium and to manage the precipitating factor of delirium. And this should be supported by a non-pharmacological care so that the symptom burden of delirium, both to the patient as well as the caregiver, is taken care of while we try to diagnose the exact cause of delirium and manage it accordingly. Medical management as such should be always used sparingly, that too for a limited period of time, and that is when we can't find out an exact precipitative factor and the symptom burden or the quality of life of both the patient and the caregivers are severely impaired due to the delirium asset. So that is what the international consensus for the management of delirium is currently. So with regards to management as such, like routinely, there are steps which we do. One is the detailed history and examination of the patient. Then we have to screen and use diagnostics tools for delirium. Then we go for investigation. So the purpose of each step is like what the name mentions itself. So in detailed history and examination, we can rule out whether there was any history of any alcohol intake or any drug intake history was there. So that whether we can find out the precipitating causes, whether any drug induced delirium or not. And also we can also rule out whether there was any history of urinary retention fever history, or any constipation as such. Because all these are certain trigger factors or precipitative factors for delirium. Similarly, examination findings also corroborate our history findings also. Like if the patient has been constipated a long time, in examination, we can find out whether rectum is loaded with fecal material, whether there is any fecalic and peritoneal examination, or also we can also rule out whether the dehydration status of the patient and whether there is any infective findings, whether it be any wound or chest examination also. And there are certain screening tools which we use for delirium, and there are certain diagnostic tools also which I put it in the next slide, I think so. And when we come to investigation, these investigations can vary from something as simple as a blood routine examination, so that we can rule out anemia or infection, like a total count, to something like serum electrolytes, the liver function test, or the renal parameters, serum calcium level, or something as intrusive like a lumbar puncture, so that we can get a CSF analysis done, or a radiological evaluations like MRI scan or a CT scan, so that we can rule out other manifestations of delirium as well. One thing or one caveat which we have to keep in our mind while in ordering investigation is we have to keep in mind the patient's diagnosis and the general condition of the patient. Because if the patient is in an end of life situation, going behind the investigations or going behind the precipitating factor of delirium is a bit of pointless. Like I mentioned earlier, the terminal delirium as such is an irreversible process. So doing a multiple blood investigation or CT scan or MRI scan in such patients are not indicated as such due to the additional burden of doing an investigation, and it's the basic principle of ethics in such situation, which is not justifiable in such a situation. However, if the patient general condition is good and if the disease is in the primary stage as such, we can go for multiple blood investigation like a CBP or LFT, RFT, or sometimes we can also go for a lumbar puncture or a radiological investigations as such in such situations. Again, the management protocol which I say it's from varies from case to case basis. It's not like one size fits all. So in certain patients, we might go for much more aggressive investigations or blood work as such. However, in certain patients, we might not go that aggressively and we might just go in to manage the symptoms of the patient as such. Like I mentioned earlier, the algorithm for managing delirium is to find out one, what is the exactly causative agent for delirium, and go with the non-pharmacological measures so that the symptom burden of the patient and the quality of life of the patient is maintained as such. So, like, I mean, these are certain tools which you can use to screen for delirium. One is the mini mental state examination, which can be used as a screening tool. For diagnosis, there are three tools which you use. One is a confusion assessment method. Then there is a delirium rating scale modified 98, and there's a modified delirium assessment method. You need to know the names of the scales, and if possible, keep one scale in your hand so that you can use it for your practice as such. So now comes to a part of the non-pharmacological management as well as the family education. So family education is of paramount importance in managing delirium as such. The reason being, most of the time the caregivers, the primary caregivers who are taking care of the patient, they might get worried and they might not understand what exactly is going with the patient, what exactly went wrong with the patient. Most of the time when we see a patient with delirium, when we speak to the caregivers or anyone who came to see the patient, the term which they use to tell us the situation of patient is that the patient has gone mad. He or she has gone mad. They are not able to recognize us. They are saying something irrelevant to us, or they are saying old things as well, or they're speaking to people who are not there, or they're speaking to family members who have passed away or dead for a long time. All this causes significant stress to the caregivers as such. So one of the studies which was published, it's called as the delirium experience. So what it found out as well, the stress due to delirium is very high in patients, not only in patients who are able to recall the episodes, and it's also very high to the caregivers also who are with the patients for the entire time. And most of the time, it's not only in hyperactive delirium, but the process of hyperactive delirium is also one which causes significant stress to the patient as well as their caregivers also when they recall the events. And uh, the caregivers of patients who are having delirium, they are found to have much at a higher risk of developing anxiety disorders also. Other thing is, whenever the patient passes away or patient dies, and in the they had terminal delirium as such, the things which the patient's caregivers recall will be the last couple of days, and the extremely agitated situation of the patient, or the extreme drowsiness of the patient, in which they might not be eating anything, will be causing significant stress to the caregivers as such. So, whenever we are seeing a patient with delirium, we have to always keep in our mind that we must speak to the care family members so that they are educated regarding what exactly is happening to the patient and what is their role in management. So what we usually do is that we have a family meeting or we talk to the family members who are there with the patient, the primary caregivers, to explain to them what exactly is happening with the patient. So their major concern is whether the patient has gone mad. So we explain to them that what is delirium as such and what can be the causes of delirium. And we also outline to them what will be our approach right now, what will be the treatment plan for the same as such. Because once we find out what exactly is the triggering factor, we might be able to reverse the delirium as such. However, one thing we have to keep in our mind is that delirium, the manifestation of delirium as such, is really heralded as a poor prognostic marker or like a marker of poor prognosis as such. So whenever we see a patient with delirium, as normally we initiate a conversation regarding what exactly delirium is, what can be the underlying factor. We need to inform them regarding the poor prognosis of the patient due to the presence of delirium as such. Other thing also we need to explain is regarding the acute onset and the fluctuating course. Because the transitory phase of delirium is one thing which confuses the patients or the caregivers. Because what they say is that sometimes the patient, most of the time due to the sundowning phenomena, the restlessness of the patient will be more during the night time or the evening time. So during entire night or evening, the patient might not be sleeping, and they might even wake up the caregivers or with the patient. So their sleep is also affected. However, during the daytime, the patient might be sleeping during the entire day or might be normal. Like he might be able to recall, he might not be able to recall what happened that previous night, but he might be able to understand who all are there with them, what exactly is happening with them. So this in turn puts a stress on the caregivers that the patient might have been just acting out the night before, and everything is all right with the patient. So we have to also explain to them regarding the fluctuating course of delirium and what is the cause behind it, and also explain to their role in management as such. I'll come back to the role in management when we go with the non-pharmacological measures of management delirium, because whenever we see about non-pharmacological measures of delirium, not only the caring physicians or the nurses, but also the family members has got an important role in managing the delirium of the patient as. And one thing which you have to keep in mind is that restraint should never be applied to a patient with delirium. And when I say restraints, I mean physical restraints. Because most of the time, the scene which we see is that we might get a referral in the ICU or be in any other ward. When we go and see the patient might be tied to the bed with gauze pieces or strings or threads as such, with rope pieces. Both his hands and legs might be tied. And when you ask them what exactly happened is, they say that patient was trying to pull out the IV line or the catheter, so they had to tie the patient up. So, like I mentioned, and the cause of delirium, like the phase of delirium is transitory or like it is a fluctuating course. So the patient might be agitated for some time, or after a certain time period, the patient might come back to his or her senses as such. During that time, what the patient is seeing is that he or she is tied down. So naturally, if any one of us we are sleeping, and when we wake up during the daytime, when we wake from our sleep, and we find that we are tied to the bed, all of us is going to be much more agitated as such. So this causes a vicious cycle. The patient agitated is increased much more higher, and we might feel the patient delirium has not subsided. We again add another medication, we add on the medications for the patient, which will further aggravate the delirium axis. So what on multiple studies have also found that physical restraint should never be used to tie down the patient. However, you can use chemical restraints. Chemical restraints, when we say, it means medications which we use for management delirium. And most of the time, the rationale behind using restraints when we ask them is that the patient is becoming increasingly combative or agitated. The patient might hit or harm himself or the caregiver. So what we usually say is that in such situation, instead of using physical restraints, use medications or non-pharmacological agents so that the patient's agitations or combativeness is controlled with the medical agents, and we should never use any physical restraints as such. So, when it comes to non-pharmacological measures, like I mentioned, always the agenda behind management delirium is find out the exact causative agent. So, there are certain things which you usually do. One is we have to look back to the medication chart and look at what all medications the patient is having. So that if it's drug-induced delirium as such, the medication we have to check whether this medication can be replaced or not, whether any alternative agent is available. However, if the medication is not replaceable or that much crucial for the patient's well-being, we have to consider whether any dose titration should be considered for such situations. Other is avoiding immobility. So if you see any patient, be it in a hospital setting or in a palliative care setting, one thing which all of us ensure is that the patient is always mobilized, being the daytime or the afternoon time or night, so that he or she is well aware of his surroundings and what time frame of the time is. Because sometimes when we speak to patients who are ICU psychosis or any ICU delirium message, one thing which they always say is that even though they can't recall sometimes they are able to recall the restlessness event, what they say is that they are unaware of what time it was, what date it was, what was happening. Because in ICUs, unfortunately, most of the time the lights are on or lights might be not. There are multiple alarms nearby. So their sleep cycle is always altered. And after a couple of days, imagine yourself being locked in a room with a light entire time and you're not allowed to go out as such. And with complete monitor beeping around you for the entire day and night. So after a couple of days, we ourselves might not be able to understand what time of the day it is, what exactly is going. So the same situation happens with the patient. So in order to avoid that, we must always avoid immobility in such situations. So the patient is always oriented. So into this, we use orientation board or familiar objects in the room. This can be something as simple as a clock to something like photos of their family members or caregivers or relatives, or something as a calendar in the bedside, so that patient is at least can see what year or what time of the month it is and what date it is. Other is ensuring there's proper bowel and bladder management so that the patient is not constipated, there's active bowel movement. And if bladder, like urinary retention is there, we have to manage that by using intermittent catheterization or permanent catheterization, or if Foley's catheter, indwelling catheter itself can cause delirium in certain cases. Such situation that should be managed. And there should be a proper assessment of pain and proper management, pain and other distressing symptoms of these patients, so that that is also taken care of. Another important thing is that we must provide visual and hearing aids to the patient. So, like I mentioned earlier, sometimes the patient in who we see might be using spectacles or hearing aids. However, once they get admitted, be in an ICU setting, as for an example, this hearing aids or the spectacles are removed from the patient. So he or she might not be able to hear clearly or might not be able to see clearly. In such situations, communicating with the patient is a huge challenge, and what the patient says will not be clear to us, and the patient might not be able to understand what we are saying. So we might mistake this as the patient is not aware or not oriented to time or place, or is communicating gibberish or something else as such, and we might mistake it as delirium. So we must always ensure whether the patient is using any spectacles or whether they are using any hearing aids, and we must ensure that these are with the patient throughout their time of admission also. So this is like I didn't put it in a chat. This is one thing which you have to, like, all the things which you have to look out for in our non-pharmacological measure. One is like minimizing the use of immobilizing catheters, IV lights, and physical restraints, avoiding immobility, promoting early mobilization, monitoring the nutrition of the patient, providing visual and hearing aids, monitoring closely for dehydration, controlling the pain, monitoring the fluid electrolyte balance, monitoring bowel and bladder functioning, reviewing of medication, reorient the communication with the patient, place orientation board, clock, or familiar objects like family photos in the room, encourage cognitive stimulating activities, facilitate sleep hygiene, including relaxing music at bedtime, warm drinks, and gentle massage, minimize noise and intervention at bedtime, like rescheduling medication, do not interrupt sleep for checking temperature also. So all these are the non-pharmacological measures which you have to use whenever patient is having delirium. And in this, there are certain correcting the correctable factors also. Sometimes dehydration itself can cause delirium. So once you watch for dehydration and we correct the dehydration, the delirium is corrected. Similarly, if there's an electrode imbalance, once we correct the electrode imbalance, be it hyponatremia or hypercalcemia in an oncologist setting, once the electrode imbalance is corrected, the delirium is also subsided for this patient. And like I mentioned earlier, when we're talking with the family member, always tell them their role in managing delirium and from the non-pharmacological perspective. So this is their role comes in reorienting the patient through their ways of communication by placing familiar objects with the patient. So what we usually ideally suggest is that be it the family members or the caregivers who are with the patient or the healthcare workers who are providing care to the patient. Ideally, if possible, the same team should be taking care of the patient during the entire course of delirium, be it the doctor or the nurse or the caregiver who is with the patient. If it's the same person, the patient himself can develop a sense of familiarity with the caregiver as well as the physician also. And in terms of reorienting communication, what we usually suggest is that whenever we are seeing a patient with delirium, before I ask that, I need to ask a question as such. Do we speak to patients with delirium? Is it important to speak with patients who are having delirium as such? Is there any importance? Just put it in the chat box. One yes is there. Anyone else has got any other opinion that we should not speak to patients with delirium? You can just feel free and put it in the chat. No issues there. So both of them have asked for yes. Speak over. Yeah. So most of the time, what happens is that whenever the patient has developed delirium, we don't speak with the patient. We only speak with the caregivers. And the reason why we don't speak with the patient is that we feel like the patient is not oriented. So there's no point in speaking to the patient. He or she might not be able to recall what exactly we are doing or the entire conversation as such. And or sometimes the patient is too agitated or too combative in nature to speak with them. However, what all the studies and multiple articles have suggested is that we must always try to speak with the patient himself or herself. And like I mentioned, even sometimes the patient might be delirious, sometimes there's a lucid interval also. So in our history and all, we must find out whether whenever the patient is having lucid interval, and we must speak to the patient so that the patient himself or herself is aware of what exactly is happening with the patient, and they are aware of the situation, what is going wrong with them. Because certain times the patient is able to recall what happened the previous night. However, sometimes the patient is not able to recall, and the caregivers might be speaking to the patient, like, what do you know what happened yesterday night? You hit us, or you pulled out the IV and you were running around here and there like a mad person. So all this causes significant stress to the patient and also affects their dignity also. Like someone saying to them that yesterday night you were doing this and that. So the patient might feel afraid of like what exactly is going wrong with. So always when you speak to the patient, whenever the patient is having delirium as such. And another thing is whenever you're speaking to the patient, be the healthcare provider, healthcare worker, or the family members, always tell them to introduce themselves before they're talking to the patient. So if it's a doctor who is going to the morning rounds, if it's a sister going to see the morning the patient, so always introduce themselves, what their name is, what their designation, what their role is in the hospital, what they are going to do to the patient. Gradually, the patient will themselves be able to recognize whether it's a healthcare provider or the doctor as such. And when we are telling to the family members, always tell them to tell their name out loud and what their relation is to the patient and where exactly the patient is. Suppose the patient is admitted in the hospital, make it a point to speak to the patient when you are speaking to the patient, or whenever the family members are speaking to the patient, that they tell the patient that they are currently admitted in the hospital and where exactly the hospital is, so that the patient gets oriented to that. So these are the certain non-pharmacological measures. Now, regarding the pharmacological measures, like I mentioned earlier, pharmacological measures are not the go-to agents for managing of delirium. All the recent studies have found out that pharmacological measures should be limited to the last stage, in which the patient is having like all the non-pharmacological measures, other correcting the correctable factors are throwing use futile. In such situation, we must go with pharmacological measures as such. And in pharmacological measures, the agents which you use are antipsychotics. So the most commonly used antipsychotic of choice is haloperidol. There are other agents also. These are quetiapine, risperidone, olanzapine, sometimes aripiprazole also. Then benzodiazepines are also used. Sometimes cholinesterase inhibitors like donazole, rivastigmine can also be used. And alpha-2 receptor antagonists like dexmedetomidine can be used. Sometimes ketamine can also be used. All this, I won't say that you need to know all the other agents. At least couple of them are things which you need to keep in mind. So one is haloperidol. So dosage which we usually start is 0.5 milligram to 1.2 of 2 milligram every 8th hourly or 12th hourly based on patient response is one thing which you do. And there are certain side effects which you need to know. These are the criminal symptoms as well as condition due to haloperidol. Other agent which we can use also uses QTPin. So again, QTPin, we start with a dosage of 12.5 milligram at night time, and we then escalate it to 25 milligram. Again, we can go with HS dosing, and based on response, we can go to BD dosing or afternoon and nighttime dosage. Again, like I mentioned earlier, QTPin itself has got a sedative action. So these are certain things which we need to keep in our mind. And certain recent studies have found that the cholinesterase inhibitors like donepezil and rivastigmine haven't been found that much beneficial in managing of delirium compared to placebo, and it's not that used right now. Dexmedetomidine is also some agents which we use in management of delirium. And one thing which you have to keep in mind is that whenever you're starting any pharmacological agent for management of delirium, we must always weigh the pros and cons with it. The reason I'm mentioning is that most of the pharmacological agents, which we start for delirium, they got a sedative action. That is, once we start the agent, the patient might be sedated due to the pharmacological agent which you're using as a. So we must always communicate with the patient as well as the caregivers regarding what the agent might be doing and the sedative effect due to the agent as such. Because sometimes the reason I'm saying we have to communicate with the patient is that sometimes the patient might be having lucid intervals. So we want to speak with them. So like if the sleep is one of the things that is having high issue for the patient, starting this agent might also help in their sleep hygiene or the sleep cycle. Once the sleep cycle is reverted, the delirium can also be subsided as such. Or sometimes when a patient is in an end of life situation, he or she might not be that much agitated. Slight agitation might be there. However, sedating the patient because the causative agent cannot be ruled out in terminal delirium. Only option which we have for such a situation is sedating the patient. Sometimes the family members might be for sedation, like so that the patient is resting the entire time. However, the cognitive impairment of the patient, that the sedation is when the patient is unable to recognize the family members or not even talk to the family members can be significant stress to them. So always have a communication with the patient's family members in terminal delirium regarding what exactly are we going to achieve with adding such agents is one thing which you have to keep in your mind as such. And like I mentioned earlier, there are certain guiding principles for management delirium at the end of life. These are do not consider the person with delirium as a list of fragmented problems or risks. Enable and foster choice. Understand the person's background and context and discover what is important to them. Activity with the staff, family, and loved ones, and provide clear explanation about what is happening and the context to it. And we must also understand that delirium disrupts the sense of continuity and is unfamiliar and should acknowledge and value their concern and make the environment more familiar and consider home, shifting the patient to home with support if that's a better location for care and always treat the person with respect and dignity. And regarding shifting the person to home, sometimes what we see is that we might feel a patient is having terminal delirium, it's refractory nature. However, what happens is that once the person goes back to their home environment itself, the delirium is subsided by itself. And we can see this when you're going a home-based care support as such. So that is also one thing which you have to keep in our mind. Always treat the person with respect and dignity and do not go for unnecessary IV lines or investigations or restraints as such. So this is one thing which you commonly encounter. You can see, yeah, I think the cartoon itself is self-explanatory. So always be sure to consider the unmet needs and triggers that might explain behavior in delirium or dementia as such. So my presentation is over. So if any doubts are there, you can just put it in the chat box. I'll stop sharing right now. Yeah.
Sir, what is difference between delirium and delusion?
So delusion as such is one of the like it's a psychiatric symptom as such. Delirium is a clinical syndrome of symptoms, right? Delusion is a symptom is what we say. So it's more than psychiatric delusion. What is happens is that the person might be perceiving one sensory input as an another manifestation entirely. That means sometimes the person might be seeing a rope or something, but he or she might be perceiving it as a snake. That's snake as such. There's a sensory input as such, but the perception of the sensory input is impaired. That is delusion, is what we say. However, delirium, like I mentioned, it's a syndrome of symptoms. It's a clinical diagnosis as such. Delusion is not a diagnosis. Delusion is a symptom which you have to rule out for further other causes. Can be delirium or can be any underlying organic causes. However, most of the time in our setting, in our practice, delusion is most commonly due to delirium is what we usually say. Even we ask psychiatry residents or psychiatry doctors also who work with us, we might be feeling like it's something organic. They might say it's delirium as such, and they might ask us to manage delirium in such situations. I hope that is clear. So
Thank
regarding
you
the
very much, Arjun. There are few uh, things in the chat box also. If someone is speaking, let them ask, and then we'll go through the rest.
okay, thanks.
Go ahead. Someone was trying to ask. Go ahead, please.
Thank you, Dr. Arjun. One small question, like
many patients, especially in ICU, they are confused. Shall we nullify and correct them about their statements? No, you are in the hospital. Sometimes they're very rigid and hyperactive. Especially in those situations, it is little difficult. What is the general approach evidence base for this?
So generally, what they usually say is that I might say it might be a cliche thing. What all the guidelines are saying is that there is not one fixed treatment protocol for delirium is what they say. We must always personalize the treatment plan is what we say. Suppose in a patient who's in hyperactive delirium, it's not about confronting the patient is no one thing which we don't usually do, but we usually reassure the patient. So hyperactive delirium, most of the time what we see is that patient will be trying to get out of the bed and go to some places. So instead of putting the patient back in the bed, you usually ask her, just sit, we'll talk to you or speak to the patient that time. It's like why exactly they want to go out of the bed, what exactly is irritating. Most of the time, surprisingly, the patient themselves will tell the reason. Sometimes they may say, I want to use the washroom. I can't go to the washroom here, even if the patient is catheterized. In such situation, we have to tell the patient like you have a catheter in place. So if you want to pass urine, it's going in the catheter, you need to go to the washroom. Sometimes it might be using for the lavatory for bowel movement. In such situation also, you might say you're using a diaper. Currently, you're too weak to go to the washroom as such. So just use in bed, or you can even promote bedside commode as such. That is one thing which we use. Instead of going for confrontation of why are you going out, just lay down in the patient, just tie down patient. That doesn't work usually. That's one thing the general consensus is there as such. Hope that is clear. So next question. There are chances that delirium can cause harm to the caregiver as well as the patient also. But once we go for restraints as such, the delirium, our entire objective of managing delirium is so that the symptoms is subside or delirium can be reversed as such. So if you're feeling harm is the thing that can cause much more severe distress to the patient, what we suggest is that using chemical restraint, like medications, like I mentioned earlier, instead of tying down the patient, because the chemical restraints, once the patient is sedated or the sleep cycle, what we have encountered in our practice is that once the sleep cycle is normalized, the delirium incidence also comes down for the patient. And usually in terminal delirium, I won't say that patient is that much agitated. Sometimes agitation can also happen. In such situation, also we usually go for sedating the patient with medications. So there is a chance the patient might harm himself or the other caregivers also, but just keeping that in mind and tying down the patient is not a good thing, is what I would say. And I think there's
You
one more
asked for
question.
some doses.
So
Can share
doses.
doses of drugs? Somebody has asked.
I do think I will share one article or something that will much more easier, I think. So for your, just for general idea, haloperidol is a medication which is usually used for delirium. And the starting doses, sometimes we even go, again, it's based on how the patient's general condition is, the weight of the patient is on. The books and all textbook all say that we can start with as low as 0.5 milligram HS. However, we usually start with 0.75 milligram or 1.25 milligram tablet, and we hike build up on it. Like we go as high as 2.5 milligram BD or even 5 milligram BD dosage also sometimes we go. Again, it's again based on what exactly is the cause of delirium and what stage of disease or what is the disease trajectory of patient. If it's in a terminal delirium, we might go for unrational dosage. Like sometimes we have even seen patients who are on 5 milligram or 6 milligram TID dosage in terminal situations. That's the dosage of haloperidol. To keep in mind, just put plus 1.25 milligram or 0.5 milligram for haloperidol and building up on that. For QTPN, I would say like 12.5 milligram nighttime dosage is the starting dose. And based on the response, we can go to 25 milligram or 37.5 milligram also. If possible, let's share one article or something which takes care of the dosage. That will be much more helpful is what I.
Yes, Arjun, that may be better. And then Sangeet can share the article to the group.
Is there any other doubts as such, or is everything clear?
That's what they can, like they have been typing in the chat, they can unmute and ask. We have got a case discussion. I think we can go on to the case discussion and then come
sure.
back. Sangeet, we can go, Dr. Yashish, there we can
Yes,
go
madam.
ahead
Yes,
with the
madam.
case discussion and then.
Good evening, madam.
Okay.
Will you put the slides or?
Yeah, I will share this.
Thank you. Good evening, everyone. I'm going to present a case about delirium. This was a patient who was discharged from ICU. She is a 57-year-old lady, very present lady, and her diagnosis for ICU was severe community-acquired pneumonia, advanced COPD, and stage lung disease. She was weaned off oxygen and shifted to HDU and later to ward. Day 3, she complains of sleeplessness and her sleep cycle was disturbed. And family tells that she has some delusions. Again, the same thing. She is seeing unknown relatives. She is calling people around her by name of relatives. And she was confused, quite little restless in the bed. Especially nighttime restlessness was much more than the daytime restlessness. Daytime, she was quite oriented if she could sleep for a few hours on day 3, but this gradually worsened. So her initial symptoms were restlessness and delusion, and sleep cycle was disturbed. Next, please. Day 3, she complains of sleeplessness and family tells she has delusions. Now, till now, we were not aware that because she was a lady, so we never thought that she would be consuming alcohol, our mistake. She gives history of chronic alcohol intake 2 to 3 packs per day, and this is what we miss. Still, she was already being supplemented with thiamine. Her sleeplessness worsened with daytime somnolence now, and the sleep cycle was disturbed. The family was bothered. There was one relative who was staying in the HDU and ward initially, but they could not manage, and later on, 2 people. Her family was disturbed. They had a leave and they were staying with her for almost a week. Then she was shifted to ward. Next, please. Thiamine and chlordiazepam oxide were continued. Melatonin was added on day 5, thinking that if we did not want to oversedate this patient because she was already an advanced COPD patient, and we started on minimal doses of chlordiazepam oxide to start with. Then melatonin was added on day 5. However, she had episodes of hyperactivity and was trying to pull her urinary catheter. Then urinary catheter was removed because we thought it is better that she passes the urine in the diaper if she cannot inform rather than injuring herself. So as discussed previously, by Dr. Pillai also, if it is a device which can be removed, we should be removing that device. Otherwise, also these devices should be removed as early as possible. Neurologist and psychiatrist consultation were done. NCCT head was done. It had few lacunar infarct, which was okay for her age. LP was advised by neurologist, but it was a clear case of delirium, so we never did an LP for this. Lorazepam was now initiated carefully. We initially gave IV lorazepam under observation, and then the dose was titrated. Our aim was that she sleeps for some time, at least her sleep cycles get better, and she had a sound sleep for 4 to 6 hours. After sleep, her behavior, her orientation was much better, and she had no delusion also when she slept. Day 7 to 9, patient had hyperactive manifestation. She was trying to run out of the bed. We have to sadly restrain her with bed sheets. And day 9 onwards, she got into the hypoactive phase of delirium. So this 7 to 9, 10 days was the most difficult period for her. For the family was also getting burnout apart from patient, and we also had concerns that this has gone for too long, despite that reason for which she was admitted to the hospital has improved, but day 9, day 10 of admission, and we are not able to control delirium was a big issue for us. Day 9 onwards, she was hypoactive. Next, please. The examination, her condition was serious, general condition, because she has sympathetic overdrive now. She was sleepless. There was some baseline tachycardia, baseline tachypnea because of increased sympathetic drive. GCS was fine, no focal neurological deficit, no neck rigidity, no localizing signs. Vitals were generally stable except for tachycardia and tachypnea. Minimal bilateral wheeze, which was there from the beginning because of advanced COPD. Abdomen and cardiovascular system were essentially normal. So we were trying to find other causes for delirium, which probably we could have missed. Next, please. There were no pressure source. Again, pressure source, especially in oncology patients, could be a big issue, which leads to delirium, often going unnoticed. ICU also at times we have pain points for the patient, especially if we are pricking arterial punctures, pressure ulcers on the nasal bridge, oral ulcers. This can also lead to delirium, can contribute to delirium. Next, please. Routine investigations were repeated from time to time and they were essentially normal. Especially we were looking for any hyponatremia, hypercalcemia. There was no major glycemic variability also. Drugs were titrated. Now this was the predicament. Are we going to oversedate or we are accepting some degree of delirium? This is always challenging, especially in patients who are neurology patients or patients with advanced COPD where slightest of excess sedation can be detrimental. Lorazepam, QT-pin, and chlordiazepoxide, all three were used at the end. Patient was sleepless for almost 72 hours. There is why where we have to initiate QT-pin also. Now, this was a big call for us. 3 days of sleeplessness is a big issue, and her sympathetic overdrive was getting high on her and on her family, and we were also very, very concerned for her now. So what we did, we sedated her with propofol under observation. Family was getting jittery, what to do, shall we shift to home, shall we opt for palliative end of life care pathway now. Non-pharmacological interventions were done from the beginning. We shifted her to a single room from HDU so that the family member stays with her. She was initially on the side where there was no sunlight in our hospital. So we shifted her to a room where was sunlight. We put a clock. We were telling her the time, day, where she is all the time. We were discussing about her family and her children. Day 15, her sleep quality was better. Her cognition was better intermittently, but there was waxing and waning, as Dr. Pillai also told. This we were still seeing this waxing and waning. If she slept well, she was better. If she was sleepless, then again she was going into the same delusion and hyperactive delirium phase. Next, please. Yeah. The psychosocial aspects for the family and for us were poor confidence for patient and the family because patient was oriented in between. So she was in fact feeling guilty. Why I'm behaving like this? Visitors and family members were attributing everything to delirium because of alcohol withdrawal. Patient was being criticized for this. Family was getting traumatized. We had discussions about long-term and home care, especially for delirium management. Her intake was getting poor. She was sleeping whole day and she was awake at night. Patient and the family were getting burnout. Risk of fall, she was trying to walk out of the bed, especially in night time. And there was baseline tachycardia now. So these were the psychosocial aspects which she and the family and we were also having difficulty in tackling. Next, please. The main concerns which were addressed, family was counseled, patient was counseled at multiple occasions. It was a dilemma for family now. Difficult choice. Day 17, they have exhausted their finances and they are seeing no significant improvement after day 15. From day 15 to day 17, she was oriented in between. Waxing and waning was there. At this time, we also discussed that she could go better because hospital setting is hospital setting. We cannot provide home settings for her. And everything was alien for her in the hospital. So we made this difficult choice and family stood by us. We were skeptical about this choice that if she goes to family, known people will be around, known surroundings, good home food, and she was discharged on request. And patient improved drastically within 24 hours at home. She called herself 48 hours post-discharge to thank the team. There was no residual cognition deficit. The memories of delirium, especially 10 to 12 days, still haunt the patient and the family, but they understand what was the etiology. We counsel them later on also, and they still visit us and they are like a family to us. They invite us for their home functions. And next, please. Summarizing the case, delirium is common in ICU patient but often goes undetected. Especially hypoactive delirium goes unnoticed. So we should be screening all our patients for delirium. Different tools have been designed to help in identification of patients with delirium. Dr. Pillai already discussed. We generally use CAM ICU in our setups. Non-pharmacological approaches have to be stressed on. Physical and psychological therapy should be encouraged from the beginning. Pharmacology treatment for delirium is a tight rope walk. We have to weigh between over sedation versus no improvement in delirium. Preventive strategies should always be instituted. As discussed, the incidence of delirium is almost 45 to 70, 80% in ICUs. So we should always be thinking about preventive strategies in ICU, in end of life care, and in a hospitalized patient per se, most of the time. Thank you, madam. Thank you. Okay, the discussion points. We have to look for delirium on daily assessment. Whenever we take rounds, we have to assess our patients. We have to modify the risk factors, the non-pharmacological interventions. Drugs, look at the drugs. Some drugs can cause delirium. We have to discontinue those drugs. Especially new drugs could be causing delirium. We have to look for polypharmacy, drug-drug interaction, alcohol substance abuse, which is quite common cause. Withdrawal of any of these agents again can cause delirium. Whatever therapy we start, we have to fine tune it. Start low and go slow. When giving medications, always monitor for side effects, especially QT prolongation. Most of these patients, especially palliative care patients, hypercalcemia, hypocalcemia, hypomagnesemia, if they have been eating poorly, could lead to prolonged QT. So most of these antipsychotic agents will have a QT prolongation effect. Always look at the side effects. Ultimately, we need to have a dynamic, individualized, personalized, and multimodal approach. Focus is on non-pharmacological intervention, and remember, one size does not fit all. Next, please. Thank you. Thank you, madam. So prevention is the key.
Very much.
Yeah.
Go ahead.
Yeah, prevention is the key. TADA method, we tolerate slight delirium, but we have to anticipate major hyperactive or hypoactive. Do not agitate the patient. Keep the belongings, hearing aid, eyeglasses, and at times home food also works wonder. Check for urine retention, bowel, and bladder function. Thank you, ma'am. That's it.
Thank you, Dr. Yash. As always, bringing up such cases gives room for more discussion. And what you have through the session and this, like it's like a revision. You go through everything and makes things more clear. So thank you very much. And let us bring it up, like if others want to, anyone who wants to add on, and Dr. Arjun, you can also add more information, whatever you would like to. Anybody else wants to like say anything that specific points in the management?
If you allow, madam, one more case I would like to bring upon.
Yes, please go ahead.
Because this is long back when we were residents, we had a patient post-thoracotomy. I don't remember what was the cause, young patient. And I was on my night call in the duty room. Suddenly the nurse called me. The patient is delirious and he pulled out the ICD. So at times it is very, and it was sudden. It was not thought of that this patient is getting delirious. So we have to screen, and very high risk patients, we have to at times physically restrain. That is a bigger challenge. Patients on ECMO, patient with ICD or post-operative drain who get delirium, it's a very, very big challenge to manage only with sedation. Or what is your take, madam, on this?
Exactly. I was also about to tell you. Yeah. I have also had one experience. What happens sometimes, one patient may go and harm another patient.
Yeah.
So I have had one such experience. It was again in HDU. So normally ICU, each patient is in one cubicle, fine. So whereas HDU, we had 4 patients in one big area. It was not a small one. So we had to use chemical. The patient who was getting agitated was again a post-operative patient. And we had another patient just exactly opposite or diagonally opposite to him. So as soon as he was getting more agitated, he was trying to get up and move. So with the nurse, like pharmacological measure is what I had to use. With the IP access, what I had, two of us. And when you do then managing such, because he was immediate post-op, like first day post-op. So then even that medication, then we had to use some face mask ventilation to small dose also. They can also respond because the sympathetic call is so high. As soon as you give the medication, they will have reduction in all their vitals and things. So you have to be very careful in these situations. So it is your last statement, no, one size does not fit all is something to be kept in mind. And one, again and again, as Dr. Pillai has been telling, use non-pharmacological and pharmacological as and when required. See, in acute situations, you will need to use the pharmacological. If you use the pharmacological, and haloperidol is very, very useful. Only thing, you should use the right drug. Haloperidol is the first line of management. That is something to be kept in mind. And then once you use these chemical methods, it's a chemical restraint, what you said. Yes, the patient will calm down and settle. Then use the time, like buying time, use that time when patient settles to explain to the family. So that the main thing is that they think, oh, something totally opposite, or why are they behaving like this? They're more worried. So once you explain, and then the restraint part can be avoided, and the patient and the carer will be in a better situation, and then correct the correctables is what important. So if you can avoid, and as someone asked me, if there's going to be some harm, you have to see how, if the carer can be moved or if the patient can be managed in other ways. See, that is why it has to be individualized. What can be done for chronic smokers, nicotine? Like you have, for chronic smokers also, you have nicotine patches. No? Nicotine patch is something you can use. And then that also there is dose titration. So nicotine patch is what, but in the question they had put, let me read the question again. What can be done for chronic smokers? Oh, nicotine abuse. Okay. For them, nicotine patches are what can be used. And then role of spiritual leaders in terminal. Yes, definitely. Like, see, you can, based on the, and that is why, like, when you think of spiritual pain, even when we were seeing in our psychology session, the spiritual pain element also has to be given equal importance, because there are plenty of studies in the last 10 years which have shown the importance, or as we say in total pain, we always, any total pain, total care, we include spiritual cause also. So that also, as someone was asking us, there are some assessment tools. You assess, then see what is needed, how you can help them based on individual, their custom belief and things. Use the appropriate leaders and what is that the patient wants and how that can be helpful. And in that front, we should know the difference between religion and spirituality. Does anyone want to say what's the difference between religion and spirituality? For the question, how common is delirium? For that, Dr. Arjun had given the statistical figures in the beginning, no? From 2 to 25% in general population and 9 to 60% in intensive care. That's that is the latest study.
Sorry to interrupt you, ma'am. Like if it's for a terminal phase
yes,
such,
please.
what
Because you are not answering, I just went in, Arjun. Go ahead.
no, sure. Like in palliative care patients, what the study says that from 13 to 42% is what they say in general. And in end of life, what they say is that one of the studies found that nearly 75% of patients develop delirium in one form or the other. So it's highly prevalent as such. Like I mentioned, terminal delirium is not such an easy thing to treat also. So, yeah.
Thank you, Arjun. Yes, because it is a big number. I think elderly also see palliative care and elderly in elderly patients also it is a large number and quite common nowadays. You see many people being diagnosed with it, and awareness has increased, I would say, because the incidence is also high. We need to be aware of it, and have we answered all the questions in the chat box? Yes, that common, that was the thing. It is one of the common issues in intensive care also. Intensive care patients itself can end up having this because of them losing the day-night rhythm or the day-night cycle. So it's very common. Then no lighting, always artificial lights, and intensive care is being busy all the time. One patient coming in may make the whole unit busy. So those type of things, everything have to be kept in mind. And when you're seeing patients. So is there any other queries anybody wants to ask? Please do. Or if not, I will hand over to Sangeet. Thank you very much, Dr. Arjun Pillai. You took us through in a methodical fashion and made sure it has been explained, and the case presentation by Dr. Yash was also so appropriate. And as we always say, the case presentation adds on more room for discussion and things. If anybody else wants to add on from the case presentation or today, please go ahead, or else I will hand it over to Sangeet.
Does anyone have to add on anything?
One second, someone. Religion, man-made, spirituality, God-made. Very well, Dr. Prem. Nice way of putting it. I'll just Sangeet 1 minute. Religion is a faith belief, and rituals, which has more predominance. That is religion. Whereas spirituality is what is the meaning of life, what is the purpose of life. So what we generally say is, so nowadays there can be someone who is religious but not spiritual, someone who is very spiritual, not religious. So these are the things, but there may be a small overlap of religious element in spirituality. Okay, so this is the broad thing to be understood. So faith, belief, only giving importance for rituals and things, that is religion. Whereas spirituality is a broader picture. It is what is the purpose of life, what is the meaning of life. So that can be, it can be a broader perspective. Okay, so and that is why in today's world they say there is someone who is spiritual but need not be religious. Any material to prepare for exam for what? Is there any material to prepare for exam for what? I don't get what topic or only for exam perspective for your FCPM it would be. Oh, Sangeet, you will have to
Yes.
give the information for that.
We are conducting. We have 5 assignments will be there, and there will be no final examination, but a posters will be there, but the marks will not be calculated anywhere in the certificate. We do have assignments.
So your assignments, assignments are the important thing, right?
As of now, yes, ma'am. As of now, there are 3 assignments released. So it's on every topic based. So after the palliative care illness topic, there will be the next assignment, and after the end of life care, that will be the last assignment. So there will be next 2 assignments which will be released in the May 29th and next June onwards.
So that's why going through as you go through the topics and then completing the sessions based on that. And score also, it has been mentioned that 80% scoring with attendance, everything counts totally. Your attendance, your assignment score, all together is what will help you to get the final certification.
Thank you, ma'am. Thank
Oh,
you,
that
Dr.
primer also has been shared. So,
Yes, ma'am.
and PPTs will be available, all information. There's also a query on the assignments number, Sangeet. Maybe you could put a message on in the group, in the WhatsApp group,
Yes, ma'am.
how many assignments. 3 if because someone had mentioned only 2 assignments. I think 3 assignments you have
Yeah, 3
already
assignments have
posted,
been
right? So that's what. So I think just
these were communicated on the beginning of the session. I will just communicate, re-communicate today also.
so that's also. I think Sri Sudha, like 3 assignments have been already given. So maybe you just put a message in the WhatsApp group of how many assignments so far have been released, and then accordingly they can. If someone has not done that, they could do that also. Okay, over to you, Sanjay.
Thank you, ma'am. Thank you, Dr. Arjum Pillai, for the wonderful presentation. And thank you, Radha ma'am, for engaging the participants and facilitating the sessions. Thank you, Dr. Yash Shaveri, for the wonderful case presentation.
Thank you.
Thank you all for
And one
participating.
thing, Sangeet, Dr. Badan is not in the WhatsApp group. It seems he is just message. So just add him on to that. Badan Kumar, thus he is not in the. I'm not on the WhatsApp group. So maybe you will have to add it on. And there are few people. Soumya also is not in the WhatsApp group, it seems. So just make sure all of them are in the WhatsApp group.
Yeah, I will cross-check with the registrations and let them know.
Exactly. Make sure all of them are in the group, the whole participants list. Okay. Thank you, Sangeet. Thank you, everyone.
Thank you. Bye.